We're going to start one of the highlights of the meeting, which is the presidential abstract competition session. I see Dr. Tourani will be joining us as well on stage. And I don't know if Ibrahim Assab is here or not. He will also join us on the stage when he does. So anyways, without any delay, these are the top-rated abstracts. This is the competition session, 5 minutes per talk and 3 minutes for questions. We'll ask the speakers to stick to time. We have 6 abstracts that we'll be presenting this morning, and the first one is entitled Predictive Computational Modeling in Optimizing Surgical Outcomes of Valve-Sparing Aortic Root Replacements, and it will be presented by no other than Dr. Jesper Horten.
Thanks. Thanks, Ismail, and no, this is not. And thanks for last night, by the way. It was excellent. This one, I think so. Yes.
If we could just shut the doors in the back and everybody take a seat, please.
So all credit for this work goes to Jur, who's the young man second from the left, a young master's student who Morten and I got to work with through Sandra in the Technical University of Eindhoven. And this idea was actually hatched last year in Boston when we talked about how can we model the effect of our surgical interventions on the aortic root when we perform valve-sparing root surgery. I have no disclosures. So the challenges of valve-sparing root replacement surgery, or VSRR, as you'll hear through my talk, there are many different geometries, different pathologies we have to take into account, and each requires an adopted surgical intervention. The goal is to use a model eventually that we can use pre-operative and pre-surgical planning to tweak and vary the different approaches we have in our surgical toolbox and see how that most effectively can lead to a healthy and coaptation of the aortic valve. So this is a physics-based computational model, which means we use finite element modeling where we can vary the geometrical variations in different pathologies. And we try to simulate the independent repair steps. In our clinic, we do the David procedure to predict the effects on post-operative functionality. So let me take you through this step by step. A research pipeline would, for instance, look like this. We would have a competent aortic valve based on the parameters that you all know from anatomy, the effective heights of the coaptation, the commissural height, and the root and the sinotubular junction radius. Then you dilate that and you create an incompetent valve of the model, and then you introduce your repair steps to see if you can create the effective height that you want to obtain. So how do we define our model? We use geometry and parameterization based on earlier work from, amongst others, Tubikar in 1990, which was excellent. But I think most notable is the anatomical correlations from Laurent de Kerkhove in Brussels in 2018, where you take the belly curve from the nadir up to the noduli of Aranti, and you have a commissural curve or the commissural insertion, and then you have a plane between those two lines that will create half of a valve leaflet. What's important is that you also have to take into account that the basal ring diameter is percentage-wise a little bit smaller than the sinotubular junction. We use the ratios from the Kerkhove's paper. So then next you induce valve pathology. So in this still, yes, simplified model, you can vary the basal ring diameter and the commissural, basal ring diameter and the radius of the commissures, or the sinotubular junction, if you will. But you also have to take into account that when tissue is stretched, that the tissue is stretched when you have dilation in your pathology. So how do you account for that? I hope the animation works. No. Well, you kind of see if you stretch the root, you increase the strain on the tissue, which makes sense. So you have to somewhere, if you dilate too much, reset the strain. So what we do is, after 10-20% of dilation, we reset the strain, which is now green, down to blue, so it becomes nullified, and then we increase the dilation, so you account for the tissue stretch. So how do we model repair modifications? In our David procedure, as you know, we measure the intercommissural height to determine our graft size. But in this case, commissural height, I suppose, is more of a passive effect. We don't vary that too much. We use that as a determinant to choose our valve graft. We look at the commissural diameter, the basal ring diameter, and the cusp insertion, or more importantly, the interleaflet triangle As you know, if you vary that, you can also influence the coaptation in commissures. So just schematically, when you have the radii commissures and basal ring, the commissural height is passively increased, and then the interleaflet triangle can be decreased, and these variables can all be tweaked independently. Okay, so let's do a case study of an effect of this model. So let's take a symmetric tricuspid valve. The geometric height is 20 millimeters. The radius or diameter of the sinotubular junction is, of the basal ring is 14, and the radius of the, from the commissure, so the sinotubular junction is 14 exactly, and the basal ring is 13. So we have an effective height here of 10 millimeters, therefore it's an effective competent valve. And now we start making it incompetent. So we use the 1-to-2 ratio difference between the commissural radius and the basal ring radius, and then we stretch the leaflets. And while we stretch the leaflets, after 10-20%, we nullify the strain so it can account for the stretch of tissue. We then look at the two repair sizes. As an example, a radius of 14 and 15 would, for instance, lead to a Valsalva graft of 28 or 30. And then we vary the interleaflet triangles and the passive commissural height effect. I have to say, free edge plication is not taken into account in this model, because that turns out to be quite tough, but we'll work on that for you for next year. Then you can make a heat map. And in this heat map, you can put on the x-axis the commissural height changes as a result of your sinotubular junction and your basal ring variation, and you look at the interleaflet triangle, and here you can see if you take a diameter of 28 millimeters graft, you have a nice effective height on the right bottom of more than 8, but if you oversize your graft, in this case with 30 millimeters, you can get a poor effective height and a malcoaptation. So in summary, we developed a computational modeling framework for valve-sparing root surgery to advance our mechanistic understanding and identify key parameters necessary for valve coaptation. Geometry acquisition is based on patient CT data. I think the holy grail in this project would be to upload all the data we have into a computer model, tweak all the variables we use in valve-sparing root replacement surgery, and then somehow predict what kind of tools we want to use for achieving effective coaptation. So thank you, and again, all acknowledgements go out to Jörg Kimmenade, a 21-year-old brilliant young engineer. So thank you.
Thank you, Jesper. This paper is now open for questions.
So that was sorry, I was a little late. Sorry, that was a great presentation, and I really believe in computational modeling. Through DASI simulation, we have now made a lot of headway on how to predict TAVR outcomes, and it's made a huge impact in our practice. The way that we did a lot of that modeling is with failures. And so really I think that have you been able to look at, and everybody says they don't have failures, but they do, because I operate on them. When these valves fail, have you been able to go back and use the failures then to teach the model on how to predict better? And that I think is where you're really going to get the best bang for your buck. And how do you do that, and what's your plans for that?
No, Dr. Ryan, that's an excellent point. I think that's the next step in the project. So we collect the failed images or images of failed repairs and re-upload that into the system and see and understand why the coaptation has not happened. There are so many valves we attempt to repair, and we follow the standardized approaches that we've all been taught, and somehow the valve coaptation is not sufficient, or we don't get the effective height we want. I think we can actually use these kind of models to tackle that gray area of patients that we're somehow not really in control of in creating an effective height. So that's an excellent point. Thank you.
I think that's really the future of how to teach surgeons. This patient is going to fail, right, and don't do a valve sparing route. This one has a 99% chance of success. That to me is the holy grail.
Thank you.
Congratulations.
I appreciate it. Thank you.
I have a question about what are the inputs for me as a clinician? What are the inputs that the model needs to provide, a CT with contrast or an MRI or what? And can this be applicable for the small babies with aortic stenosis? We were discussing yesterday the options for the infants with aortic stenosis, whether we have a high probability of adequate repair before getting them into surgery, and can we try different types of repair? How do we use this model? Is this web-based, or this is an app that needs to be downloaded?
Yes, this has to become readily available and ideally open source for everyone to use. I'm a strong believer of that. Yeah, so this is why we work close with Morten. Morten Smerup is a congenital surgeon in Copenhagen. We had to start with the adult, larger valve geometry because there's so much anatomical
So
work
not
done on
applicable
that.
to children.
But then we're going to move over to the congenital. Yeah.
And what input do we need?
I think that MRIs and if MRIs and echo is probably going to be the inputs we need for this. Yeah.
This is CT scan related model or
Yeah,
MRI?
and which has drawbacks.
I think a fusion of T and CT would be phenomenal.
Yeah.
Okay.
Thank you
very
for
much.
your
Thank
time.
you.
Appreciate it. Thank you.
So next we move to the second presentation by Dr. Kaneko. He's going to talk about the propensity-matched 8-year outcomes following surgical aortic valve replacement with novel calcification-resistant versus contemporary tissue bioprosthesis.
Thank you so much, Dr. Kapadia, and congratulations on a very successful meeting in Egypt. It was fantastic. Yes, this one, yes. It was a fantastic dinner yesterday. So my presentation is regarding propensity-matched 8-year outcomes following the aortic valve replacement. This is SAVR with novel versus contemporary tissue bioprosthesis. These are my disclosures. So the background of this study is that the selection of valve prosthesis depends on multiple factors, including age, life expectancy, ability to tolerate anticoagulation, and patient preferences. And the durability of the bioprosthesis for surgical aortic valve replacement is an especially important consideration in patients with longer life expectancy in terms of structural valve deterioration, reoperation risk, and survival, especially with this concept of lifetime management, which is expanding. Resilia tissue is a bovine pericardial tissue incorporating a novel integrity and preservation technology. I won't go into the details too much, but what it does is it caps the free aldehyde ligating factors so that it can delay some of these deterioration. This has been installed on the surgical aortic valve, mitral valve, and transcatheter valves, and it has an impact on both fields since this will be implemented into other valves in the future. So excellent outcomes of Resilia tissue have been demonstrated through 7 years. All-cause mortality was 85.4%, with a structural valve deterioration of 99.3% at 7 years. So the objective of this study, going through the SAVR outcomes through 7 years, being the longest term clinical data published on Resilia tissue. However, the limited data exists comparing this novel tissue to contemporary tissue valves. So the aim of this study is a comparative 8-year analysis has been undertaken that compares SAVR clinical outcomes of Resilia and non-Resilia tissue valves. So the methods in the study design, the objective, I'm not going to repeat it again, the endpoints are all-cause mortality, SVD, reoperation, and reoperation due to SVD. I do have to mention that the definition of SVD in this study is not a VARC2 or VARC3 criteria. This is based on the STS-AATS-Aikens criteria, which was utilized at the time of these studies. So the study cohort for the Resilia tissue is a commenced valve N of 689 patients, and the other comparative arm was through the Magna-Ease PAS. So the comparative arm specifically used Magna-Ease. The most important part of this study is that the commenced valve is a valve frame from the Magna-Ease. The only difference is that it uses the Resilia tissue. This is the study synopsis. I'm not going to go through each of it, but the main difference is that the Magna-Ease PAS did not have a core lab, where the Resilia study had the core lab. This is a baseline summary of demographics. The patients with Resilia was older, had more male, but had less class 3 and 4 patients. The main age group was between 50 and 65, 65 and 65 to 70, and the main valves that were utilized was 23 and 25 millimeters. You can see that the Resilia tissue, about 50% was aortic stenosis purely, whereas about 70% on the Magna-Ease, but there were more mixed pathology on the Resilia tissue. We had multiple concomitant surgery. About 50 to 60% were isolated, and all the others included CABG and other surgeries. So to match these patients, we performed what we call a IPW using these 14 variables. And after the matching, you can see that these two groups match very well based on the absolute standardized differences. So the first outcome we looked at is freedom from mortality. And you can see that between the two groups, there were no difference. When we looked at the freedom from valve-related mortality, which is another important metric for mortality, both groups did extremely well. The next outcome that we looked at was freedom from SVD. When we compared the Resilia versus Magna, you can see that the Resilia tissue had superior SVD at 8 years compared to Magna, and this held true for freedom for reoperation due to SVD, as well as freedom from reoperation, as you can see here. So looking at the summary of 8-year safety events, these are freedom from the safety events, you can see that the Resilia tissue did better in major bleeding, SVD, non-SVD, reoperation, and reoperation due to SVD. We did look at the cause of SVD since we thought this was very important. When we compared the two, Resilia had 2 cases that required SVD and reintervention. Both were stenosis, where the Magna E's majority was stenosis, but we did see cases with regurgitation as well as mixed disease. Half of these patients were treated with valve-in-valve. Resilia tissue demonstrated clinically stable hemodynamics through 8 years. You can see the stability of the mean gradient as well as EOAs. The study does have several limitations. These clinical trials are not intended to be directly compared due to potential biases and confounding factors. And the hemodynamic data comparison was difficult. You saw that the Magna-E's didn't have the hemodynamic data because of the site-reported study. So in conclusion, this propensity score match analysis, Resilia tissue valves are proven to have better rates of SVD reoperation due to SVD and all-cause reoperation at 8 years than the non-Resilia tissue valves. Clinically stable hemodynamics were observed in the Resilia cohort, supporting excellent valve durability through 8 years, and these data support the choice of Resilia tissue bioprosthesis for SAVR in patients aiming to maximize life expectancy while minimizing cumulative risk. Thank you very much.
Outstanding presentation. One question is that for the size of the 2 valves, it looked like that in the Resilia tissue, there were more 25 compared to 23. Do you think that the size was one of the differences? And another question was that the curve separated fairly early for SVD. So why do you think that the valve failed so early and not after a few years?
Yeah, so I'll go one by one. Yes, definitely. There were more 27 and 29 in the Resilia tissue as well. And it also, that probably reflects a study period. These commenced studies were done a little later, where the concept of these patient prosthesis mismatch has expanded. We did put some of the parameters, like BMI, in the propensity matching, but we might have to look at it as subgroup analysis for a large valve, whether that has an impact. The second question was, Samir?
Early separation of the curves when
yes.
you looked at the
SVD, we
right?
did look at that, the patterns of SVD, and there were some early failures from SVD, mainly from stenosis in the Magna E's arm, which we don't see that often, but that's what we saw in very detailed analysis. So maybe there is a difference between the two, and maybe we just haven't recognized.
Good morning. Can you comment on the completeness of the follow-up? I noticed in the slide showing the hemodynamic data, I think data was available for only 200 patients or so out of the original cohort of 689. Do you have a sense of the completeness of follow-up?
Yeah, that's a very good, great question, and we just didn't have time to go through it. The COMMENCE trial, unfortunately, originally was supposed to follow up for 5 years, and correct me if I'm stating something that's incorrect. But after 5 years, I think FDA thought that these data were very important. So we actually asked the sites to go back and report the outcomes until 10 years. However, they were able to do it only on the high implanting sites. So that's why, despite the entire cohort having 680 patients, the follow-up after 5 years diminishes because of that.
It was a subgroup of the sites that were asked to re-consent the patient, and that's not an easy thing to do when you finish a trial and then you re-consent the patient for that. And that was the rationale behind that, Yoshi.
Chris, short question.
Yeah, my question is about why are your data so good, and yet when we look at TAVI versus AVR data, that data makes AVR data look so bad.
Great question. I think part of it is because the VARC2 criteria. I think SVD does include patient prosthesis mismatch. So, like I said, this data SVD definition was based on some of the old STS ATS criteria. So PPM is not included. And I think PPM is what makes SAVR so much worse on these SVD comparisons, just because we're not implanting big enough valves. I wish Boyan was here. He would be thrilled with your question.
Great, thanks, Yoshi. And I think it just highlights the importance of the ISHRM standards. Emmanuel's in the room and Hanekkar is in the room. These are the standards that we should be using going forward for reporting valvular outcomes. Thanks again, Yoshi. We'll move to the next presentation.
So the next presentation will be the in vitro study of the effect of geometric differences on bioprosthetic aortic valve hemodynamics, presented by Nicolas Bueno.
So hello everyone. Today I will present our in vitro study of the effect of geometric differences on bioprosthetic aortic valve hemodynamics. So calcific aortic stenosis affects more than 2% of the populations, and currently there is no medical treatment to prevent the onset or the progression of the disease. And an option is to treat it with a surgical or transcatheter valve replacement. There are more and more bioprosthetic valve replacement, but their main limitation remains durability compared to the mechanical valve. So to test durability, accelerated wear tests simulate 5 years with 200 million cycles, but it's not realistic due to the high cycle frequencies. So hemodynamic testing are shorter and use more realistic hemodynamics, and thanks to specialized method, we can we can reveal early signs of poor durability. So durability can be impacted by different factors, such as the hemodynamics, biological factors, and also the design, which can lead to tear and calcifications, especially in the region with the higher strain, higher mechanical stress. So in order to create our parametrical geometry, we have combined a XUERL design with a tubercular design, one for the leaflet and one for the base. And this gave us this geometry. And we also modified this geometry essentially to bring the leaflet closer. And then by adjusting the parameters, we can easily generate multiple geometries. So we wanted to create different valve geometry using a molding process, and that's why we developed a Blender add-on that was used to generate the valve geometries and the mold geometries. So here you can see the 3D model of the mold with the stent and the corresponding valve. This allowed us to 3D print the mold and to fabricate the valve by molding of the silicone. So here you can see our normal geometry. It's a reference geometry based on the trifecta valve. And we generate 9 variations of this geometry by changing one parameter at a time: the diameter, the height of the leaflets, and the leaflet curvature with parameter x3, x2, and x1. And also we had 2 other valves with thicker leaflets. And you can see the silicone valve we obtained here. And this silicone valve were tested in our cardiac simulator, which is composed of left atrium, which is column water, the bioprosthetic mitral valve, and then our left ventricle that is activated by a piston pump. Then there is the aorta, and the rest of the systemic circulation is replaced by compliance under resistance. So the trifecta valve and the 10 silicone valve were tested under normal physiological conditions with these conditions, and we measured the mean transportative pressure gradients, the effective orifice areas, and the geometric orifice areas. So to validate our silicone model, we compare it with the trifecta valve, and you can see in the table below The TPG, the EOA, and the GOA are quite similar. For the TPG and the EOA, we measure it with echocardiography. And for the GOA, we use a high-speed camera, and we use our custom-coded Python program to detect the GOA, and we were able to plot this over time. So here you can appreciate all the GOA detection for all the geometries. You can already see there is different behavior in the opening for different valve. For example, the valve X3 has a small GOA due to the excess of leaflet tissue. And as expected, the valve with a thicker leaflet and just also a small opening geometric area. These visual observations are well represented here in the plot, where you can see the thicker leaflet valve and the X3 valve at the lowest GOA, and as expected, the valve with a 25 millimeter diameter had a better GOA, and more surprisingly, with the highest highest leaflet valve, it also have a good GOA. For the TPG, it follows the same pattern as for the GOA, with leaflet curvature, the small diameter, and the thickness of the leaflets, and worsens the result for the TPG. And the bigger diameter and the change in height of the leaflet, and just improves the TPG. And it was the same pattern for the effective orifice area. So, the essential to remember, silicon valve can replicate a different design of prosthetic valve, and the valve geometry impacts hemodynamic performance. So the thickness of the leaflet, the belly curvature, and the small diameter worsen the result across all metrics, and the bigger height and diameter improve the hemodynamic performance in the valve. And this parametric approach can be used to optimize future valve design. So the next step will be studying the valve behavior during diastole in order to assess the strain field on the leaflets. Then study the patient-specific geometries with or without calcifications, and also perform some numerical simulations with fluid structure interactions for better understanding of mechanical and flow behavior. So thank you.
Excellent presentation. So one question I just was trying to understand, that you use the silicon valves rather than using the commercially available valves. And what was the main purpose of doing the silicon versus the
because we wanted to test a variation of parameters in the geometry, and it's not available on the market, all the different kind of geometries we wanted to recreate. So we need to fabricate our own valve to have all the geometry we wanted. This allows us to cover a large field of different geometries.
That was Nico. That was a great presentation. Is the goal to create a polymer valve, a silicone? Is that the goal, or is to find out what's good today compared to the other valve types?
The goal is not to create a valve, but it's just more to have some insight on the parameter, geometrical parameter, which can induce maybe some degeneration of the valve. So here we can find that an increased belly curvature worsens the result in hemodynamics for the hemodynamics performance of the valve. But maybe other good valve here with the hemodynamic point of view are not as good as this for the deformation point of view on the leaflets for the strain. So
it's always difficult because of the immunologic response that occurs in the rheology of blood versus what you're testing in a simulator model. So it'll be interesting to see the next steps for this project.
yeah, thank you.
And how do you account for cusp characteristics from one valve model to the other? Do you just assume that silicone is the same as all bovine pericardium, or every valve design is different and you just try to mimic that as best as possible?
I didn't understand the question.
What I'm saying is that you use silicone to mimic the prosthetic valves, the commercially available valves, but what properties does silicone have, and how do they compare to cusp material, bovine pericardium or such?
Yeah, we use a silicone that is as close as possible as a trifecta tissue leaflets. It's a bit more elastic than the trifecta valve, but it was not possible to find a silicone with the exact same properties, and so that's why we use this silicone. And I think, in my opinion, for the opening behavior of the valve, the strain is not very important in the leaflets. It's more on the closure phase where it will be very important to have a good material.
Great, thank you so much.
Next we'll have the presentation by Dr. McGrath. We are going to discuss the trends in incidence and outcomes of surgical conversion for transcatheter aortic valve replacement in the United States.
My name is Yang Zhan. I'm actually representing the group to present our research work, and we appreciate the opportunity. So transcatheter aortic valve replacement, TAVR, has rapidly growing as a major therapeutic modality for patients with aortic stenosis. Despite advancements in TAVR, interprocedural complications can still occur and may require conversion to open surgery. Therefore, European and American guidelines recommend centers performing TAVR procedures have on-site cardiac surgery backup. As TAVR outcomes continue to improve and operator experience continues to increase, there has been a question if on-site cardiac surgery backup is still necessary. Well, the idea to have a no cardiac surgery backup seems to be provocative for the TAVR practice. We think it is important to look at the contemporary real-world TAVR experience. Therefore, we investigated on the incidences and the surgical outcomes of the conversion cases in the United States in the recent years. We queried the National Inpatient Sample Database for all adult patients who underwent percutaneous TAVR procedures from 2017 to 2021, and we used the ICD codes to identify relevant diagnosis and the procedures performed. Our definition for conversion was any open cardiac surgery procedures performed on the day of a TAVR procedure or on the following day. The patients were divided into the conversion and the no conversion groups. Here is the study design. After we identify the patients of interest, we look at the conversion and no conversion groups for demographics based on characteristics and outcomes. The second analysis was to identify risk predictors for conversion and the mortality, the risk factors among the converted cases. So among a total of 68,141 patients identified, 410 patients, 0.6%, underwent surgical conversion. Here you can see from the figure, the incidence of conversion appeared to be uptrending while the in-hospital mortality continued to decrease over time. The demographics and based on characteristics of the two groups were compared. The conversion group patients actually were younger, but had the similar comorbidity burden, and the conversion group had a higher rate of liver disease, malnutrition, rheumatic heart valve disease, but lower rate of for example, prior CABG surgery. Not surprisingly, the patients in the conversion group had much worse outcomes, including in-hospital mortality, which is much higher, and all the individual complications, except the permanent pacemaker rates, were similar between the two groups. We then look at the independent predictors for conversion and found that the liver disease, malnutrition, and the rheumatic heart valve disease were positive predictors for conversion. We next look at the converted cases, looking for the predictors for mortality. Besides older age, female gender, and variables indicating hemodynamic instability during the TAVR procedures, such as cardiac arrest or ECMO requirements, appear to be the positive predictors, as well as the variable suggesting severe cardiac injury, such as bleeding during the procedure, predicted the mortality after conversion. In conclusion, our study revealed an increase in the incidence of surgical conversion on TAVR patients. Mortality associated with the surgical conversion appeared to have been decreasing over time. The risk factors we identified may help with procedure planning and the improvement of TAVR outcomes. While current procedure protocols may not adequately prevent these complications, we feel at this time there's continued need for surgical backup. Thank you for your attention.
I have some questions, but you go first.
I think, could we just find some details about the TAVI planning and the data of the pre-procedure and the anatomical or access indicators of the risk of conversion? Because when we are planning for TAVI, I see most of the risk factors are maybe some significant difference, but the incidence is very low, so that we cannot say that the one with liver disease or a woman or some age, even conversion was more in younger age, that is 73. No, I thought younger age maybe 60, 50 somehow, no, 73. So I think the main important factors are what should we consider during the procedure. Like in percutaneous balloon mitral, there are indicators that the valve will rupture and we will convert. Do we have something like this for TAVI?
Yeah, so I have a slide for limitations, but I didn't have enough time to present. So because there's a major limitation with the database we use, so there's not a whole lot of granularity in the data. For example, on anatomy or indication of the procedure, etc. So that's just why we have to rely on the demographic data and the variables we can actually identify from the database. I think the overall take-home message is it can basically happen to anybody. It surprises actually the patients were actually younger in the conversion group. So, and we hypothesize actually the other way around. So
if we could identify some 2 or 3 major centers with highest rate and subsequently higher rate of conversion, we can contact the centers and do some mutual research with them as to the preoperative characteristic, anatomical access and procedure characteristics, because this is very important while planning for TAVI, and sometimes the conversion is delayed.
Absolutely. So the interpretation, you're right that the NIS data is very limited, but the interpretation of the fact that, as you can imagine, many of the patients who require open surgery may not have open surgery because you're trying to figure out that whether you should do it in the centers or not. It is very possible that the people were younger because those people, they thought that it could be salvaged, whereas the other people, they never did it.
Correct.
So how do you interpret this information to say whether surgery is needed or not? Because I think centers which did not have good surgery would not be part of this, because you don't know how many people required surgery and how many people had surgery.
Yeah, that's very true. Good point. So we don't really have the entire picture of conversion, honestly. There are patients who actually were managed, conservatively first, then eventually, maybe days later, and required conversion, but which is not really included in the definition we used for this procedure. So in order to have the entire picture about the catastrophic complications during the TAVR procedure, I think it'd be better to have a sort of a registry or something, that can include all the patients who require sort of a SAVR or cardiac surgery procedures afterward.
Yeah, there's a lot more to talk about on this, but I think we're short on time, so we're going to go to the next topic. Good job.
Thank you.
So the next topic will be polymorphic size of lipoprotein A and structural bioprosthetic valve degeneration. It'll be presented by, is it Roman? Is that? Yeah, great, Romain.
So thanks for the introduction and the invitation to present our work today. So dyslipidemia has been associated with occurrence of SVD in several clinical association studies. And this study have raised the hypothesis that there is a potential recapitulation of the early processes observed in native calcific aortic valve stenosis in the context of SVD, and particularly with the activation of a fibrocalcific mechanism that is driven by the L-lipoprotein particle and the inflammatory cells that infiltrate the prosthetic tissue and then activate the pathophysiological process leading to SVD. Lipoprotein a is a genetically determined cardiovascular risk factor that has been strongly associated with an increased incidence and progression of native calcific aortic stenosis. So what about lipoprotein a and SVD? There is currently two studies. One is retrospective study. The other one has only a short follow-up period post-intervention that report the association between LPA and SVD. And there is conflicting results between these two studies. One is positive, the other one is negative. Another important point regarding lipoprotein a is that there is different polymorphic size of this lipoprotein, which is characterized by the number of ApoA Kringers-4 copy number. So you can have a large polymorphism with a long ApoA, and a short polymorphism with shorter ApoA. Interestingly, some studies show that the small lipoprotein polymorphism are associated with a worsened atherogenic profile. So the objective of our study was to determine whether lipoprotein a plasma level and or the lipoprotein a polymorphism size were associated with SVD. So we use the TransLink clinical trial, which is a prospective multicenter clinical trial that includes patients at the time of surgery in the group B1, and then patients who underwent aortic valve replacement 4 years, and they were recruited 4 years after this initial surgery. So today we will mainly focus on this patient recruited 4 years and more after the surgery. So this patient underwent a comprehensive Doppler echocardiography and to define the stage 3 SVD based on VARC-3 criteria. And so patients with SVD were classified in the group A and patients without SVD in group B2. There is also a subset of patients that underwent compute tomography to determine bioprosthetic calcification score. We measure in the plasma the circulating LPL level by classical methods, and using mass spectrometry, we determine the LPA polymorphism size, which is the ApoA Kringer's 4 copy numbers. The primary endpoint is the presence of significant SVD, which is the comparison between group A and group B2. We have a few secondary endpoints. The mean gradient as a surrogate, as a continuous marker of SVD, bioprosthetic calcification assessed by CT. And also in the group without SVD, we look at newly diagnosed stage 3 SVD in a follow-up study that has been performed 1 to 2 years after the enrollment in the study. So here is the characteristic of the patient. So the cohort is a classical cohort of patients who underwent aortic valve replacement. And there is few difference between patients with and without SVD. The SVD patients are a little bit younger, more female, and at a lower blood pressure. And there is also a small difference in terms of the time from surgery, time from the initial surgery. There is 8 months longer in the SVD groups. When we look at the association between LPA plasma level and the ApoA Kringer's copy number, you can see a significant inverse relationship within the range of what is published currently in the literature. But what is important to look at on this graph is that for an individual lipoprotein plasma level, a given plasma level of LPA, you can have a very different number of Kringers in your lipoproteins. So this means that the number of Kringers can bring new information in addition to the circulating level of LPA. So now, when we compare patients with and without SVD, there is no difference in terms of LPA concentration. However, the patient with SVD presented a smaller ApoA Kringer's 4 copy number. So the association between the small ApoA Kringer's 4 copy number has been validated after multivariate analysis with the occurrence of SVD. So there is a 3-fold increased risk of developing SVD for this patient, even after adjustment for circulating LPA. This has been confirmed with the secondary endpoint, so the mean gradient and prosthetic valves. And finally, regarding the newly diagnosed SVD, so out of the 256 patients without SVD, 203 patients underwent the follow-up echocardiography 1 to 2 years after the enrollment in the TransLink study, and 46 patients were newly diagnosed with stage 3 SVD over this follow-up. Interestingly, the newly diagnosed SVD patient had a lower ApoA Kringer 4 copy number, and the small ApoA Kringer's copy number has been validated after multivariate adjustment. So to conclude, the study showed that LPA with small polymorphism size are associated with an increased risk of developing SVD or progression of SVD. And this raised the hypothesis that LP lowering therapy that could be initiated at the time of surgery could be a potential therapeutic option to limit or delay the occurrence of SVD. So I would like to thank all the TransLink Consortium and you for your attention.
Outstanding presentation, very well done. One question is that you obviously did a univariate analysis to say that this particular protein affected the SVD or not. Did you take any other factors in consideration to say that this was an independent predictor, or this was just one of the predictors?
No, we perform multivariate analysis. We adjust for all classical clinical risk factor. We also adjust for the time from surgery because there is small difference between the two groups. And this multivariate analysis confirm the association. We also perform a match analysis of patient. We match the patient for age, sex, and time from surgery in 52. So we have 52 patients in both groups, and the association has been confirmed.
That was very nice. Thank you.
Thank you.
Thank you. In the interest of time, we'll just keep moving. Thank you, Romain.
Thanks.
So our last abstract this morning will be presented by, is Pouya Yousefi here? Is Emmanuel presenting for him? By Emmanuel Lansac, and the title is The Learning Curve for Standardized Valve-Sparing Aortic Root Replacement Using the Remodeling Technique and External Ring Annuloplasty. Comparison between reference and proctor centers from 18 countries. Emmanuel.
Thank you very much. I'm presenting instead of Pouya, who is not able to be there, had to cancel his trip for family reasons. So it's actually not, he put my name as a first main thing, but he's the main author in this multicentric trial from the Valve Research Network, from the Heart Valve Society, with many centers who contributed. So as you know, there is a possibility to standardize the aortic valve repair, and this was the work according to the phenotype with remodeling and annuloplasty, or ascending with annuloplasty or double annuloplasty for isolated AI, in order to restore the ratio between the sternocleidomastoid junction and the annulus. And we focus on the learning curve of a standardized approach of valve-sparing root replacement with remodeling and annuloplasty. So the technique had subvalvular annuloplasty with stitches, lining up the free edges of the cusp prior to root reconstruction, and then remodeling root reconstruction in a symmetrical manner with three tongues or two tongues for bicuspid and tricuspid, resuspend the effector fight, and do the annuloplasty at the end. The idea of the trial was to assess the reproducibility of the technique and compare the outcomes of the standardized approach of valve-sparing root replacement using the remodeling technique with external annuloplasty between the reference center and the proctor center. Endpoints where primary endpoints are all-cause mortality, freedom from aortic valve reintervention, and freedom of AI superior to grade 2. They were all those patients were coming from the formal Aviator registry or the aortic HVS aortic database. And we had 18 countries participating, 19 centers, more than 1,100 patients, and a follow-up year of 4,900 patient year. Here are the characteristics. The 30-day mortality was similar among both groups, and there was no particular main difference. As you see, the cross-clamp time was longer in the reference center as a proctor center, so it means that maybe sometimes you teach two people and they go faster than you, so that's good. Good to see. For long-term survival, there was no difference, and so that was good to see. With a 99% at 9 years, and linear rate for all age was 1.2% death for all age, and below the age of 60.6%. Freedom from reoperations as well, there was no difference. But if you look into the detail, although there was no difference, if you omit the 10 first cases, the freedom from reoperation, I mean, the reference center was 94%, but the freedom from re-op if you omit the first 10 cases was 90% in the Proctor Center. If you omit 20 patients, 95%, and so you're going back to the same level of freedom from reoperation as the reference center. When we look at AI grade 2, there was a difference, and reference center had 94% freedom from AI, significant AI, while Proctor Center with less than 10 cases was 81%. If you omit the first 20 cases, it was rising up to 87%. And if you omit the first 30 cases, then it went to 95%. So this, the difference did not become significant again. The higher risk factor for reintervention was infective endocarditis. And when we look at factor for reintervention, immediate post-op, mild to moderate, so patients coming out of the OR with more than grade 1 were higher risk factor of reoperation, and this is well known, particularly if the jet was eccentric. So this means that we need to be extremely strict in our criteria within reoperation. So when we look at the risk factor for recurrent AI, as well, the number of cases matter. If you do less than 9 cases, it was a risk factor. Less than 5 cases a year was a risk factor. This difference disappeared after the first 30 cases in each center. So in conclusion, a standardized approach of valve-sparing root replacement using a remodeling technique with external annuloplasty is reproducible with long-term results with similar survival and with similar data on outcomes between reference center and Proctor Center. The learning curve is around 30 cases, and immediate post-op AI, and particularly eccentric jet, are higher risk factor of recurrence of AI, so you need to be very strict and not tolerate this 1.5 AI that will lead to be a grade 2 or 3 immediately and will lead to reoperation, so being very strict on grade 1, less than grade 1 central AI. Thank you very much for your attention.
Emmanuel, thank you. This is important data, but I'm just surprised by the conclusion. You're saying that basically beyond 30 cases, regardless of the annual volume, the learning curve disappears, and whether you're just doing less than 5 cases a year, the outcomes will still be the same? Or is it similar to what Maral showed with the Ross data, whereby it doesn't matter how many you've done, it's just really a matter of doing consistently year after year, at least 10 or 11 cases, 1 a month, let's say, to be able to maintain good safety and good efficiency of the operation?
I would not be as strict into, I mean, the data, I think these are, when after the first 30 cases, there is the individual learning curve, but then, so if it's one operator, but then if you integrate other operators, he will have his own learning curve, so volume matter, we all know that. And but it's interesting to see that at least even in lower volume, if the surgeons commit, then you can have a reasonable data, but from experience as a proctor, I can see that if they don't have the volume, then you forgot in between cases and repeat mistakes.
And some of these patients, some of these sites then, I think 1 a month is great, Ismail, but I would tell you that some of these, in the United States, an average center does 1 AVR CABG a month, okay, for the center, not the individual surgeon. So I think it'll be 2 to 3 years for most people really do 20 cases a year of this. So I think that's what I walk away with, is that those that are doing less than 10 training, you have a 20% failure rate. So really have to watch this very carefully, I think.
Any questions from the audience?
No, I was just one quick question for me, as an observer from a cardiology side, to say 20% failure rate for people who are learning is a big deal, because in my mind, to say that it will take 3 years to learn. So for 3 years, if you have reasonable volume to get to 30 patients, so should it be not restricted to very experienced site to do this operation, rather than try to teach a lot of people to do it, because there is a penalty, not penalty, but there is a risk to pay for the patient, because 20% is a large number for...
You mean 20% for AI?
AI.
Yeah, sure, of course. And I mean, at least in France, contrary to the US centers, if you do less than 500, you cannot perform cardiac surgery, period. So that's also a matter of raising the numbers, and I think raising that bar a little even higher to have a decent volume to be able to address all patients, because all patients don't move to big centers. And I think it's our part of regulation, but getting specialized aortic centers of course matter, and also raising the bar in terms of volume for each center to have the decent volume for each subspecialty, I think also matter. It's both sides.
Yeah, so maybe because I think we're time to a little short here. Emmanuel, as always, a very provocative paper that ends this session, so congratulations.
Thank you.
So thank you to all the speakers. Thank you to the audience. We'll reconvene at 9:15. We're going to just reconfigure the stage here, and at 9:15 we'll start the plenary session. Thank you.